Welcome to the MamasteFit podcast. In this episode, we're going to be talking all about labor stalls and what type of movements that you can do to help resolve some labor stalls. We're going to break down the 3 reasons that you may have a labor stall, but in this episode, we're specifically going to be talking about labor stalls related to your baby's position and the path or the passage that your baby is navigating through. Welcome to the MamasteFit podcast. This is Gina, perinatal fitness trainer and birth doula.
And I'm Roxanne, labor and delivery nurse and student midwife.
And this is the MamasteFit podcast, where we empower you on your prenatal fitness, birth, and postpartum return to fitness journey.
Our podcast shares how to move throughout your pregnancy to stay strong and comfortable, because pain is not a requirement of pregnancy. Understand the science of birth and how to approach recovery after birth.
We share our personal experience as mothers navigating this stage in our lives, plus our professional expertise as birth workers and fitness professionals.
Our goal is to help you feel confident as you navigate the perinatal timeframe for an empowering pregnancy, positive birth, and postpartum journey.
We are glad to have you with us on this journey and that you have chosen us to support you. So welcome to the MamasteFit podcast. In this episode, we're going to be talking all about labor stalls. So first, let's define what is a labor stall. And a labor stall can be a normal pause in your labor that can occur because you're tired or you're really hungry. And so your contractions are just naturally slowing down to allow you to sleep or to eat. It can also be a normal transition between different phases of labor. So when you go from early to active labor or active labor to transition or transition to pushing, there can be normal lulls in between those phases as your body kind of gets ready for the next phase. So at times, there can be very normal pauses or slowing down of our labor that occurs. Now, if you have a labor stall that is related to like a quote unquote issue with your labor, this could be related to your baby's position. So baby's having a hard time navigating through the pelvis. Maybe they're not well aligned to the pelvic level. Maybe their chin is not quite tucked, so they're not presenting small enough to fit through the pelvis. Or maybe it's related to the space or the passage that baby is navigating through. So maybe there's restriction, like some tension, like muscularly. Maybe there's limited movement in some areas where there's decreased pelvic space. And so those are 2 reasons that could contribute towards labor stalls. Another reason that we may have a labor stall is related to the power or the strength of the contractions. And this will be something that we discuss in the next episode, which we'll be talking about why you might have like a decrease in level of contractions, maybe more spacing out. So a power stall could be related to your fatigue levels, your hunger levels, how you're feeling mentally. So whether or not you feel safe and supported in your space. Are you holding on to any other fears associated with labor? Maybe you've had a prior experience or somebody really close to you has had a prior birth experience that you're hoping not to also have again or to be similar to them. And then it could also be related to your health. And so next episode, we're going to be talking all about stalls related to power. But this one, we want to specifically talk about labor stalls that are related to the passenger or your baby's position, and then also the passage, because those 2 are really intermingled with one another. So Roxanne, what are some common definitions of a labor stall? Like when can someone be like technically classified as an arrest of labor or a labor stall?
So labor stalls or arrest of labor is what it's more commonly used in medical terms. And this is just labor has slowed down and there's no like actual progress in labor with a cervical exam. So this means that the dilation has not changed, the station has not changed, as well as the effacement, and even baby's position within the pelvis. So baby might still be like 0 station, but we can tell that baby is starting to rotate. That could be defined as a change as well. Not every provider is very skilled on determining like position of baby on every vaginal exam, but it can be a sign of labor progress if your baby is repositioning itself, even if like all of the other things hasn't changed. But that has to occur over 4 to 6 hours, depending on some factors. Most of the time, though, they will call arrest of labor or lack of labor progress and will recommend a C-section after 6 hours of no progress, with them even like implementing interventions, such as they put Pitocin on, they broke the bag of water, and none of those things has allowed labor to progress still. So if they've given you Pitocin and they broke your bag of water and they also placed internal monitors to determine the actual strength of your contractions, and all of those things say that you are having an adequate contraction pattern that should lead to cervical dilation, position changes, and all of those things that labor is progressing. If none of those things happen, then that's when they would recommend a C-section. Some providers will do all of those interventions at once. Some will do one at a time. So this would be like a good question to ask your provider to see about like how long after if my labor doesn't progress, what would you recommend? And like what timeline would you normally give somebody? And there are many different reasons, as Gina's discussed, for a labor stall. But with active labor, like spontaneous active labor and induction, the definitions are different because if you're being induced and you just never got to active labor, that is not an arrest of labor because you were never in labor. It's just labor never started. So this is what some people will call like a failed induction because they could not induce your labor for whatever reason. Maybe baby wasn't tolerating or you were just being induced for 4 days and nothing changed. And this was like a medically necessary induction. That would be more termed like a failed induction. I hate to use the word failed, but that is what they will normally put it as. And then arrest of labor or a labor stall, that is when you came in like spontaneous labor, you were in active labor, and then something happened to cause your labor to stop. Or with that induction, you got to active labor and you were 5 to 6 centimeters making some good contractions, making some change, and then all of a sudden it stopped. Those would be more arrest of dilation labor stalls versus like you were in induction and it just never progressed to active labor. Both of them could still lead to that C-section because labor is not progressing. You cannot be in labor for weeks and months and days without needing other interventions. But that's typically what they'll put is the timeline is 4 to 6 hours, again, depending on like what interventions they put into place, and then whether or not you were actively in labor spontaneously or by induction, or if you never got to active labor via induction.
So I definitely find that probably a lot of C-sections are related to whether or not labor is progressing. Now, there are obviously like emergent situations that can occur, but the majority of unplanned C-sections are likely due to labor stalls or arrest of labor. So it's important to know what to do if your labor does stall or pause. And you don't have to wait for the 4 to 6 hours of labor stopping to then start implementing different measures to try to progress labor. And it's also important to note, like Roxanne was discussing and how I had discussed earlier, there are different reasons that may contribute towards a labor stall. So Pitocin is a tool that's available to help increase the strength of contractions, but it's not the only tool that you need to be using to help address a labor stall, because sometimes the issue is not how strong the contractions are. Sometimes the issue is, what is baby's position? Is there enough space within the pelvis? Can you create that space? So first, let's talk about baby's position. And we're going to focus on each pelvic level because each one has different things to consider. So for the top of the pelvis, or the pelvic inlet, where baby is first entering or engaging, this is where we can sometimes see like a slowing down of labor, especially the transition from early to active labor. So baby's just having a hard time getting into the pelvis. And so usually what I'll see, and I would love to know what your experience is as well, especially with like inductions, is usually someone's anywhere from like 4 to 6 centimeters, but they're just like not progressing into active labor if their baby has not yet entered into the pelvis. And so that'll sometimes be like a longer stall for some folks. Is that similar to what you've seen as a nurse?
Well, so most of the time when we admit someone for spontaneous labor, they are past that 3 to 4 centimeters. But not every baby is engaged. So sometimes we will have people show up to the hospital in that early active labor and we won't admit them because they're still at 2 to 3 centimeters. And it might take them a while to get to that 3 to 4 because baby is not engaging until like we either like give them some tips as they're walking around the hospital to try to see if they could get baby to engage with like hip tucks or something. And it's usually like a couple hours that they're like trying that before baby will engage, and then they'll like quickly progress through to active labor. But inductions, I do find that with inductions, if we get somebody to that 3-4 centimeters, but baby is not engaged, that it makes the induction a lot longer. And so they'll get an epidural to try to rest because it takes a while to get to 3 to 4 centimeters for some people. Like people walk around 3 centimeters that they like worked up to over like weeks. And some people are 3 centimeters in a millisecond, but a lot of us, like, you do like these practice contractions and it slowly gets to this 3 centimeters. And we're kind of forcing it in a very short period of time when you're being induced. So it could just be like everybody's natural labor pattern. Like, it just takes a while to get there. But with an induction, we want you to go faster. So getting to 3 to 4 centimeters can take a really long time. And then if baby isn't engaging, whether like because you got that epidural to rest and maybe you just need a little bit more help repositioning now because you're not intuitively moving, it can take a really long time to get like to 4 or 5, 6 centimeters because baby is having more trouble engaging.
So usually the signs that I'll see that the issue with this labor stall or pause that we're seeing is related to baby's position, especially if baby is still high in the pelvis, is your contraction pattern will be irregular. So you'll have like coupling or grouping of contractions where it almost feels like a really long contraction and then like a bigger gap. And then you'll have like another grouping and coupling of contractions and then a bigger gap. So it'll be like 2 back-to-back contractions, big gap, 2 back-to-back contractions. The other thing that sometimes my clients will feel is they'll feel like their contractions are double peaking or they feel like an irregular like bumpiness to the top. So usually when we have a contraction, it builds, there's like a pretty solid peak and then a release. If baby's position is a little bit off, sometimes the peak kind of feels like there's multiple peaks. So I would always call it like a bumpy contraction where it feel like there's like a bunch of squeezes happening. And this is essentially your body trying to help rotate the baby into a better position so they can align and enter into the pelvis. And so those are the 2 big signs that I'll see is contraction pattern is kind of irregular. They're kind of back to back, or the peak of them kind of feel very bumpy is like the best way that I can describe it. So if you're noticing that, it could be related to your baby's position. And this can apply at any point during labor as well. But we're specifically talking about the top of the pelvis just so that as you move through your labor, you have a reference to what tools to be using. And so if baby's in the top of the pelvis, they're trying to enter the pelvis, your contractions are like, you'll have like a bunch of really intense ones, and then they'll kind of like not be so intense, and you'll have some more intense ones, and then they won't be so intense. Again, this is just your body kind of helping baby rotate and shift. And then once they kind of align baby to the inlet, they'll enter. But what movements can you do to help with this progress? Because sometimes we can integrate some movements to help speed this process up a little bit or to make it a little bit more comfortable. The first is going to be to find some sort of inversion. Now, if your contractions are more than like 10 to 20 minutes apart, I would even say even more than like 5 minutes apart, doing like an open knee chest position, which is a part of the mile circuit, which is essentially your chest is on the floor, your butt is up in the air, and we're looking for an angle that's greater than 90 degrees between your torso and your thigh. So open knee chest doesn't mean that your knees are wide. It means that the angle between the knee and the chest is greater than 90 degrees. And we'll include some pictures and stuff down in the show notes, or we'll include like a blog that shows what these different movements look like as well. So that would be the position that I would do if your contractions were more than like 5 to 10 minutes apart, because you can maintain that position for a really long time. You can also just do puppy pose, which is just hips up in the air, chest out on the floor, because again, you can maintain that for a prolonged period of time. And this can sometimes help baby readjust their head position and help them kind of rotate into a position that feels really good for them. So I would hold that for about 20 to 30 minutes, and then I would focus on opening the top of the pelvis, particularly the upper mid pelvis. And so if your baby's having a hard time entering to the pelvis, sometimes it's because they aren't well aligned. And so when we open the top of the pelvis a little bit more after those inversions with like fire hydrant type poses. So if you think of like a dog peeing on a fire hydrant, it looks just like that. You put a bunch of pillows underneath the leg to support it, or like a peanut ball, for example. You could also do like an exaggerated sideline position where one leg is on top of a peanut ball and it's kind of pushed out a little bit. So what we're really looking for is one hip to be in a very open position. And when I say open position, I mean the knee is moving away from the center of the chest. So if you had both your knees right in front of you, if you spread one knee out to the side or even both knees out to the side, so you think like really wide knees, that would be an open hip position. And that's what we're trying to achieve to help open the top of the pelvis and that upper mid pelvis area.
External rotation.
External rotation. So if you try to find positions like that, it can create more space in the top to help baby have an easier time entering into the pelvis. Something else that could be the problem, quote unquote, that's making it harder for baby to enter into the pelvis, particularly the top of the pelvis, is your ability to find a posterior pelvic tilt. And so this means you're able to tuck your butt underneath and kind of tuck that sacrum under, which is going to create more space front to back in the top of your pelvis. So all of those wide leg positions and externally rotated positions are creating more space side to side, but we also want to create more space front to back. And commonly during pregnancy, finding this more posterior pelvic tilt or that tucked butt position can be more challenging because this tends to be a movement pattern that is just harder to find because it's kind of the opposite of our movement tendencies. We tend to favor a lot of extension or arching in our back. And so it's finding the opposite where we're really rounded can be really problematic. And so you can do things like hip flexor releases, either like a half kneeling hip flexor release by yourself. Your partner can support you in the half kneeling, or you can do a sideline one where your partner is stretching essentially the front side of your thigh. And again, in the blog that we'll link with the show notes, we're going to have a bunch of pictures and stuff as well so you can see what those look like. But those would be kind of like my top tips to help your baby enter into your pelvis is one, doing an inversion. This can help baby kind of adjust their head positioning, adjust their body positioning so they're better aligned to the pelvis. If your contractions are about 5 to 20 minutes apart, I would do an inversion that you can hold for like 20 to 30 minutes. So like an open knee chest, like a puppy pose position. If your contractions are like 2 to 3 minutes apart, but you're noticing that they're kind of bunching up together, or you're just like not feeling like you're progressing, but they're really close, like a forward leaning inversion, which is the hips are pretty much stacked on top of the shoulder. So it's a lot more upright. Holding that through 3 contractions can be really helpful. After you do the inversions, you can either focus on the hip flexor releases to help you find more of that posterior pelvic tilt or that rounded back position, or you can do positions that help to open the inlet and the upper mid pelvis, which is primarily going to be those like wide leg positions. And again, we're going to link the blog so you can see what these positions look like. And if you follow us on Instagram, we've definitely posted these exercises as well. So those would be like my movement tips to help address baby's position and also help address creating more space in the top of your pelvis to make it easier for baby to enter. Because again, your baby's position in the space within your pelvis tends to be really intermingled. And the good news is you don't have to wait till birth to try to create this space. Like we can focus on all of this during our prenatal workouts, during your prenatal yoga sessions. Like you can do all of this mobility work during pregnancy and so that we can make sure that we're creating that space. And so the MamasteFit birth prep circuit is something that we like to recommend. It's a free circuit. There's about 6 exercises in it. And we primarily focus on helping you find more of that posterior pelvic tilt and internal rotation, which is something that we're going to address as we navigate through the pelvis.
So if you have an epidural and your baby has not yet engaged, something that you can do, because like obviously all of those things do require some sort of movement, you can still do a lot of those movements even with an epidural. With the inversion, obviously you're not going to be able to go into like a puppy pose or a forward-leaning inversion, but you can do what's called Trendelenburging the bed, which is where you just drop the head of the bed and raise the feet up, so that you are in a gentle inversion. With an epidural, though, you do not want to hold this for too long because an epidural does work by gravity. And if you are upside down, the epidural medication is just going to go upwards towards your head, which we do not want. But you can still be in somewhat of an inversion to get the benefits of this with all 3 levels of the pelvis. An inversion is really beneficial, so you can do it at any point. With an epidural, to help the baby engage, we're going to want to do something called flying cowgirl, which is, there are 2 variations where you're just using a peanut ball, or if you don't have a peanut ball, you're just using pillows between the knees to create that open hip external rotation. Feet are coming together, and then you can either stay like that or you can bring the hips forward into full extension to create that posterior tilt of the pelvis while having that exterior rotation of the hips. And this, you can just stay on 30 minutes on each side. So you're going to be side lying when you do this. And I've done it many times during my labor and delivery career. And it's always been pretty helpful for most people when like their baby is having trouble engaging into that pelvis. I will say I did it during pregnancy when I was in early labor and trying to sleep. With my pregnancies, and I was in that early labor, and I was like, I just want to go to sleep. I did put pillows between my knees and slept in like a modified flying cowgirl. I don't know if it helped, but it was comfortable. So
Even with an epidural, you can also do the fire hydrant position and the side lying position as well to help create more space in the upper mid pelvis. The difference between those movements versus the flying cowgirl is the flying cowgirl is primarily an inlet opening exercise, while the fire hydrant and the side lying movement are going to be primarily an upper mid pelvis. So it's going to open more one half of the pelvis, which can help with baby's rotation. So if baby's not well aligned to the pelvis, sometimes those two movements can help baby rotate to better align to the pelvis, while the flying cowgirl is going to open the top of the pelvis more, which can also create enough space to help baby rotate, but also help baby drop into the pelvis if they are well aligned. So tons of options to help you baby enter the pelvis if that is more of the issue that you're having. But with all of those, we do need strong contractions as well. So next episode, we're going to talk about how to make your contractions stronger, but let's move on to the inlet or the mid pelvis now.
All right. So the mid pelvis. So how do we find out where our baby is within our pelvis? This is a question we always get when we're talking about labor stalls and the different levels of the pelvis. One, if you don't have an epidural, your intuitive movement is going to tell you kind of where you are, where your baby is in your pelvis. The other option is your providers can, your nurses, your doctors, your midwives can tell you what station baby is in. So if they check you and they say your baby is -2 or above, then that is an inlet issue. So baby is having trouble engaging into the pelvis. If baby is -1 to +1, this would be that mid pelvis. So then this is where we're at now, that mid pelvis.
The intuitive movements that you could be looking for is you're primarily favoring a lot of side to side type movement patterns. And where we're going to see more of the issues with the mid pelvis, this is going to be more of our late labor stalls. So this is where you're like 7, 8, like 9 centimeters, and then you just stop progressing. So this is where I usually see more of the mid pelvis problems. And this is because baby's having a hard time finishing their rotation. So inlet problems, baby's having a hard time entering the pelvis and beginning their rotation into the pelvis. Mid-pelvis problems are usually babies having a hard time finishing their rotation. And so what we're going to be looking for to help create more space in the bottom of the pelvis is we want to find more of those closed hip positions and internal rotation of the hip, primarily on one side. Most babies are rotating on the left side, and so usually when we want to focus these type of movements on the left side of the body, but you can do either side, especially if you're unmedicated or you don't have an epidural. You could just kind of choose whatever side feels better for you. And there will be a side that you're like, this feels right to me, while the other side will not feel right for you. And so what we're primarily looking at with these closed hip positions, so it's essentially the opposite of the open hip. Instead of the leg moving away from the center of the body, the leg is moving towards or even past the center of the body in front of you. So we're bringing the knee towards the opposite hip, for example. So when it comes to our late labor stalls related to the mid-pelvis, usually babies having a hard time rotating or finishing their rotation underneath the pubic bone and out of the pelvis. And so you're probably going to be anywhere from like 7, 8, or 9 centimeters, and then you're just kind of stuck. Babies maybe like a 0 station, like a +1 station, and they're just like not really moving anymore. And so what we want to do to address these late labor stalls is we want to focus on more internal rotation at the hip, because this is going to create more space in the lower half of the pelvis. And so once we kind of hit like 0 station, +1 station, this is the narrowest part of the pelvis for a lot of us. And so this is why we may have some issues towards the end of labor. In addition, for a lot of us, internal rotation tends to be really hard to find during pregnancy, because we tend to favor a lot of external rotation and that extension, kind of like I talked about for the inlet. And so we're already decreasing space in the bottom of the pelvis because these are our common prenatal postural tendencies. And so what we want to find is internal rotation to create that space. And what that looks like are closed hip positions. And so if you remember, open hip position is the knee is moving away from the center of the body. So we're coming into our wide knee positions. Internal rotation is essentially the knee is coming towards midline or even passing, maybe even like crossing your body. So you can think like knee moving towards opposite knee or opposite hip, or you can think like knees in, ankles out. And that's also going to help you find some of that internal rotation and create more space on the bottom half of the pelvis. You can also find like hip shifted positions, which are going to be that closed hip position without having to like really torque and rotate in the knees. And so if you're familiar with our Instagram, you've seen tons and tons of hip shifted exercises, because those are so beneficial to one, releasing tension in the back half of your pelvic floor, which for a lot of us has a lot of tension. in addition to helping you find more of that internal rotation that is harder to find during pregnancy and can impact your birth. In addition, internal rotation is really important for pelvic stability and hip stability. It's how we stabilize within our pelvis. It's a part of our glute range of motion, so it's going to help to strengthen your glute. If you can find that internal rotation, improves pelvic floor function, and then, of course, helps with labor stalls and helps you navigate through the birth. So things that we can look for hip shifted positions is one, we can find a hip shift, either standing. If you're upright, you're essentially just rotating the pelvis on the femur to rotate that pelvis or belly to thigh. You can do it standing, you can do it in all fours, either fold a pillow to put underneath your knee. You can be in all fours and just shift your weight towards one side. If you have an epidural or you're feeling more fatigued, your partner can do like hip shifted, like a partner supported hip shifted position. And again, I know a lot of these names are probably like, I don't know what this all means. The blog that we're going to include with this is going to have a lot of examples within it so that you have an idea of what a hip shift even looks like, so that you know what type of movements that you can include into your labor. And so finding more of that opening in the bottom half of the pelvis usually helps baby kind of finish their rotation underneath the pubic bone so that we can then get to pushing. And we typically see a lot of progress from there. And again, you don't have to wait till birth to try to figure out how to create more space in the bottom half of your pelvis. We can do that during pregnancy with our prenatal workouts, with our birth prep circuit. And so our birth prep circuit, that's free for you. There's 6 exercises within it. It includes that posterior pelvic tilt exercises, in addition to the internal rotation exercises with that hip shift. So you can practice these movements during pregnancy. You can make sure they're accessible to you so that you know that you can create space within your pelvis. If you want to join our prenatal fitness programs, we incorporate all these hip shifted, all these internally rotated, all these pelvic mobility exercises within our programming so that you can prepare for birth in addition to feeling strong throughout your pregnancy, feeling comfortable throughout your pregnancy. Our programs are designed to not only support your pregnancy, but also help to support your birth and your labor progress as well.
So with the passenger labor stall, so baby's position being off, some like having trouble navigating through the pelvis in some sort of way, why does our contraction pattern give us such a clue as to what baby is doing inside? And this is because if baby is positioned or like having some difficulties getting through the pelvis, our body is really smart in knowing that, hey, this one contraction isn't a lot like pushing this baby down. So I need to work harder to get the baby to go through and finish those rotations to be born. But they also know that baby only has so much like oxygen in its gas tank to be able to withstand contractions. So during contractions, all the blood supply, like majority of the blood supply is cut off to the baby. And that is when they're getting all of their oxygen and nutrients through that umbilical cord. But during the contraction, they're not getting any of that. But like our babies have this little gas tank of oxygen and nutrients to withstand the stress of those contractions. And they have about 10 minutes. A healthy baby has about 10 minutes of fetal reserve is what it's called. So if you have like 2 or 3 contractions in the row, like baby will have a long break to be able to fill that gas tank back up in between those contractions. So this is why you will have either the bumpy contractions, a bunch of them in a row where it seems like you're just nonstop having contractions. Then you'll have a really long break in between, like 4 to 5 minutes in between. And then again, you'll have like 2 to 4 contractions in a row. But they know they can't just keep having contractions nonstop until baby's position is fixed, because baby eventually the gas tank will run out and they won't have that oxygen. And then this is where we'll start to see that fetal distress on the monitor. So the body, again, is smart. It's going to do as many contractions as it can to kind of help that baby reposition and then give that long break. So when I see that on the monitor, then I can assess like, where is the baby within the pelvis? What positions do I likely need to do to help this baby finish these rotations or kind of reposition themselves so that they're able to enter and navigate through the pelvis easier and with less work on the uterus's part, because that is the best indicator of baby's position. Whether the baby is trying to engage or likely baby is in that transverse position. So instead of them facing forward or back, they're facing one of the hips. So it's called OT. That is a sign, like if baby's in the lower mid pelvis, that is the best sign that, hey, this baby is having trouble like finishing that rotation when I'm seeing those coupling contractions, or even most of the time it's 3 contractions in a row with a long break when they're just trying to finish that rotation. If they're trying to engage, I normally see like more bumpy contractions when they're having trouble engaging into the pelvis, which is kind of cool that it's like different parts. The contractions do different things. But some people will say, oh, you're having a lot of back pain. Oh, your baby's in a bad position. We need to fix that. When some people just, that's how they labor. Some people just have back labor normally, such as me. It's not great. Don't recommend. But some people, that's just how their labor normally goes. So it's not the best indicator of when we need to intervene for a baby's position. I find contraction pattern is one of the best indicators of whether or not we need to intervene, as well as obviously labor progress, not progressing.
Usually I find if you have more back pain or back discomfort during your menstrual cycle, you're more likely to have more back labor during labor. And so for my clients that have more like back discomfort during their menstrual cycle, and then they're having back labor, it tends to be just the way that they labor, unfortunately. It could be related to like your uterine position or the way that it sits within your pelvis. Some folks have no back labor at all, but I usually get a little frustrated when somebody is experiencing back labor and then somebody is suggesting that this because of an issue as opposed to realizing that for the majority of people, it's just like a normal part of labor. Now, back labor could be an indication of a positional issue if it's also paired with that coupling or that irregular contraction pattern. The reason why you may experience back labor if baby's in kind of a funky position is because of the way that baby's kind of pulling away from the sacrum. So they're really stretching on those uterosacral ligaments that attach from the bottom of the uterus to the sacrum. So you may be told like, oh, you're experiencing back labor because baby is pressing really hard into the sacrum. It's actually the opposite. They're pulling further away, which can cause some of that back labor. Now, again, for some of us, this is just our normal uterine position, and so we have more back labor. If it's not something that you normally experience with your menstrual cycle or your contraction pattern is like super regular and there's no indication of an issue, it could just be the way that you labor, unfortunately. TENS unit, sacral massage, heating pad, water are going to be your best friends during your labor.
So with labor stalls, the reason that learning about labor stalls and what are the different causes of labor stalls with passenger especially is that one of the top reasons for unplanned C-sections during labor is that baby is in some sort of funky position and not being able to fit, quote unquote, into the pelvis or fit through the pelvis. And this is like one of the top 3 reasons for someone to have an unplanned C-section. But it's also something that we can address during labor and identify during labor to be able to potentially avoid that reason for having a C-section. Because we can address when potentially a baby is having trouble navigating through that pelvis and fix that. Pitocin is a tool, and it is a great, great tool, but it is not the solution to every labor stall. And not every person looks at the reason of a labor stall to then find the solution. Pitocin, a lot of the time, is a solution for every labor stall. But if your baby is not in an optimal position for your pelvis and needs some help and needs some more room to be able to navigate through your pelvis and be born, giving Pitocin is not going to solve that position. It is not going to make your baby magically in a better position unless we are creating the space for them to be able to find a more optimal position for them.
So one way that you can think about it is if we use Pitocin for every single type of labor stall, it's similar to if you have a square peg with a square hole. They're meant to fit with one another. But if I align the square as like a diamond shape and I'm trying to ram it repeatedly into the square, it's not going to fit no matter how hard or how strong the Pitocin is. But once I rotate the square and fix its position, it's now going to fit easily into the pelvis or into my square hole. So the square peg and the square hole are meant to fit with one another, but if they're not well aligned, similar to if your baby's not well aligned to your pelvis, they're going to have a hard time fitting, and it may appear that they're not meant for each other. But once we rotate it, then they can more easily fit. So this is a big reason why Pitocin is not always the solution to helping adjust baby's position if that is the reason for your stall. And similar to the Pitocin is not always the solution if the issue is that there's decreased space or mobility within the pelvis because of maybe some muscular restrictions that we need to release, or maybe the position that you're currently in is decreasing space within the pelvis. So if you're favoring a lot of external rotation and we're trying to create more space in the bottom half of the pelvis, This is going to make it appear like the pelvis is too small for baby to navigate. And so while we can increase the pitotia and continue to ram and ram and ram, once we create more space in the part of the pelvis the baby is navigating, they may have an easier time moving through to either enter into the pelvis or finish their rotation out of the pelvis. Let's take a break from this week's episode to talk about one of our podcast sponsors, Needed. Needed is a nutrition company that focuses on optimal nourishment for the perinatal timeframe. So they're helping to supply supplements and nutrition for preconception, during your conception phase, pregnancy, and postpartum and beyond. Roxanne and I have both used Needed throughout our preconception phase, throughout our pregnancies, postpartums, and even our husbands use the men's line as well. And so it's a brand that we love and trust, and that's the only reason that we share it with you is because it's something that we personally use. And one thing that we want to talk about in this episode is their vitamin D supplement, which is something that can be really beneficial throughout your pregnancy and towards the end of pregnancy as you're preparing for postpartum, especially if you're planning to breastfeed.
So vitamin D is one of the vitamins, or some people will even call it a hormone within our body that has so many functions that we don't even understand all of the functions of vitamin D. But it is vital for like our bone development as well as like potentially our pain sensors. And we get vitamin D from the sun, from our diets a little bit. And many of us are deficient in vitamin D. One, because a lot of us work indoors. We're not outside all the time getting vitamin D through the sun. We're inside with fluorescent lights. So healthcare workers like myself are very vitamin D deficient. And I didn't learn about vitamin D's importance until I was pregnant with my first, and I got a chipped tooth because my vitamin D levels were 15. Normal should be like 40 to 50. And it was affecting my teeth, my vitamin D deficiency. So like calcium absorption, magnesium absorption can be affected by our vitamin D levels. So if you don't have adequate vitamin D, you're not absorbing calcium or phosphorus or magnesium very well, which all of those things are really important for our immune system, our bone, our teeth. And vitamin D can also, if you're deficient, cause you to have an increased pain during labor, which no one wants more than they already have to endure. So vitamin D, getting your vitamin D levels checked during pregnancy, postpartum, preconception could be so beneficial. Needed has a vitamin D testing kit for you to do at home that you can collect your own blood, send it into the lab, and then they'll tell you what your labs are to determine how much vitamin D you should be supplementing. Because with everything, you can take too much of any supplement. So you want to make sure that you're taking the optimal dosage for your body. So Needed has a test, and then they have vitamin Ds that you can then take. During pregnancy, you can ask your providers to do a vitamin D at your prenatal appointment. So I had my vitamin D checked during my prenatal pregnancies. I think all 3 of them did vitamin D checks. And that's the first reason how I found I was deficient, because I got a random check during pregnancy. But it can be so beneficial to understand one, what your levels are, and 2, how to be able to increase your levels. So check out Needed's vitamin D. You can use our code MamastePod to get 20% off your first order or the first 3 months of your subscription at thisisneeded.com. Let's get back to the episode.
So if your labor does take a pause or stall for whatever reason, remember that sometimes it can be a normal pause. So if you're feeling fatigued, you're hungry, maybe you're transitioning from location to location, or you're transitioning within your own labor from phase to phase, these can be super normal pauses within our labor that just happen very normally. Now, if you have a prolonged stall or you're noticing some of these signs associated with like baby's position potentially being issues, such as that coupling of contractions or those bumpy contractions, then we may want to start doing some things to help address baby's position so they can better fit through our pelvis. Remember that your baby is meant to fit through your pelvis, like their heads are going to change sizes, your pelvis can change position and size. And so they're meant to fit through, but sometimes they're just like not well aligned to the pelvic level they're trying to navigate. Sometimes they don't quite tuck their chin, so they present smaller. And so doing different movements prenatally and then also during your labor can help ensure that your baby can enter into your pelvis and then help finish the rotation out of the pelvis. If you know where baby is within your pelvis, it can also help you better address what type of movements to do. So if they're still trying to enter the pelvis, primarily focusing on movements that help and open the top of the pelvis, versus if baby is really low in your pelvis and they're having a hard time finishing that rotation. So maybe you're stuck at like 8 centimeters, or maybe you've been pushing for a really long time and baby's just not getting underneath that pubic bone. Focusing on opening more of that lower mid pelvis with those hip shifted positions can be really beneficial to creating more space to allow baby to finish their rotation through the pelvis. And like we talked about before, you don't have to wait till birth to try to figure out how to create more space within your pelvis. You could do all of this prenatally as well. So one, we want to ensure that baby's path to rotate is clear. So the musculature and the surrounding tissues that your baby is going to be moving through are clear of restrictions. Now, it's impossible to completely be tension-free. We will still have some tension within our body, but trying to ensure the uterine ligaments are balanced with one another. The pelvic floor is balanced. That baby can easily kind of move around to whatever position that they need is going to be one thing that you could do during pregnancy, as opposed to trying to force baby into one specific position. The next thing that we can do is to ensure all of the different movement patterns that are necessary to open each pelvic level are accessible to you. So external rotation for the top, that asymmetrical movement for the middle, and then internal rotation for the bottom are some examples of movement patterns that we want to be able to have, especially in our hip, to create more space within our pelvis. If you want to dive way deeper into solutions for labor stalls, because there's so many out there, in addition to labor positions that open each pelvic level, both for an unmedicated and an epidural birth, plus things that you can do prenatally to prepare to open your pelvis, you can join our online childbirth education course, and you can use code STORY10 to get 10% off any of our bundles. All of our bundles are already 15% off, so with the additional 10% off, the bundles will be about 25% off. Now, when you go to checkout, it's not going to be 25% off because the bundles are already 15% off. It'll just be an additional 10% as our gift to you. In next week's episode, we're going to talk about the labor stall related to power, which is the strength of contractions, which is where Pitocin could potentially be a beneficial tool for you. So if you want to learn more about labor stalls and the solutions to help with your labor progress, be sure to tune in to next week's episode. Thanks for listening to this episode. If you enjoyed it, be sure to like and subscribe to our channel so you get notified whenever we release new episodes. We release new educational episodes on Wednesdays and new birth stories every Friday. If you're pregnant and you want more support from us throughout your pregnancy, join our prenatal fitness programs and childbirth education courses. If you're postpartum and you want more support to help you return to fitness after birth, you can join our postpartum fitness program. And now we have a postpartum education course that also includes infant massage and infant CPR. If you're a professional and you want to learn more from us and NCUs, you can join our birth workers course and our fitness trainer course.
This podcast is sponsored by Needed, which is a nutrition company focused on the perinatal time frame, and you can use our code MamastePod for 20% off your first order or the first 3 months of your subscription at thisisneeded.com.